Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips and Practical Tips. What I'm going to be sharing with you today is a nice example of anorectal melanoma. So this is a case of a 75-year-old male patient who was complaining of bleeding per rectum and was found to have an anorectal polyp. And this is the large polyp that was excised with rectal glands and surface ulceration. And there is this growth of malignant cells underneath. And on high power magnification, large cells, lots of pleomorphism, abundance of mitosis, and a pleomorphic nuclei with a prominent acidophilic nucleolus and some areas showing pigment. Now, these malignant tumor cells were growing in between the glands, and as you can see here, the prominent nucleolus, which is an excellent clue to the diagnosis of melanoma. But what was really surprising is the presence of those malignant cells invading in a pagetoid pattern the rectal glands, and these are the tumor cells in between. And there were areas deep in the lesion with the cells containing the brownish melanin pigment. And with immunostain, SOX10 is an excellent robust stain for melanoma. It's a nuclear stain. Because of that, it's much easier to interpret. And the tumor cells a strong diffuse positivity with SOX10. But what was really nice is the cells that I showed you before, the malignant melanoma cells spreading along the basal layer and then into the crypt of the rectal glands. And then HMB45 shows usually cytoplasmic granular staining was also positive, and again highlighting some of the cells spreading into or invading into the rectal glands. However, one issue with HMB45 is that because of the presence of melanin pigment, which is the darker pigment that is present here, sometimes it might be difficult to interpret the cytoplasmic positivity in the tumor cells. So remember, if you can find a nuclear marker like SOX10, it would be much easier to interpret, especially in the presence of melanin pigment, abundant melanin pigment in the melanocytes. Now, the BRAF immunostain was interpreted as negative. This is the melanin pigment. And as you can see, there is this fine granular staining, but it was everywhere, even at the endothelial cells, involving some of the nuclei. Because of that, the final interpretation of the stain was negative. So the final diagnosis for this case is anorectal melanoma. Anorectal melanoma is a rare tumor, usually seen in elderly patients, accounting for less than 1% of all tumors in the GI tract, including the anorectal area. Remember that the presence of melanin would help in supporting the diagnosis and rendering the appropriate diagnosis using the appropriate immunohistochemistry. However, if melanin was not present, you have always to keep it in mind. Remember the tendency for the melanocytes to spread along the rectal glands, and remember that melanin, sometimes melanin pigment might hinder the interpretation of cytoplasmic staining like HMB45 or melan A. Now, anorectal melanoma, you should report on surface ulceration, you should report on the depth of invasion, the presence of vascular invasion, lymphatic permeation. However, until to date, still it does not have a TNM agreed on staging system. I hope you find this tip useful in your daily practice. Thank you.